I want to say thank you to the organizers for asking me to give this talk today, and I'll be talking to you about update on endoscopic interventions for obesity. These are my disclosures. I've been involved in multiple studies in the endoscopic bariatric space, and I also consult for multiple companies as well. There are multiple different types of endoscopic bariatric primary therapies, and that's what we're going to focus on talking about today. The space-occupying devices, the non-intragastric balloon gastric devices, suturing and plication devices, and the small bowel therapies. We think that the small bowel therapies actually do have weight loss independent effects, where we think the rest of the devices really have improvements in metabolic function because of the weight loss they achieve. And our focus today will be on the devices that are either approved for use in the United States and have already undergone FDA evaluation, have been studied for FDA approval but not yet approved, and are currently undergoing FDA evaluation. So we'll first talk about intragastric balloons, and there's lots of different intragastric balloon types in and around the world, with endoscopically placed, swallowable, and then variable different types of fill. And you can see the different balloons here: fluid-filled balloons, air-filled balloons, the air and fluid-filled balloons, the gas-filled swallowable balloons, and the fluid-filled swallowable balloon. In the United States, the Orbera balloon, which is a endoscopically placed fluid-filled balloon, is approved, as well as the Obalon balloon system, which is gas-filled and is swallowable. The spats and the ellipse balloon have undergone FDA evaluation but are not yet approved. And the reshape balloon was previously approved in the United States, is no longer approved, but only because of regulatory paperwork issues, not because of any issues with the device itself. So the Orbera balloon is a single fluid-filled silicone balloon that's placed with transoral delivery. It's filled between 400 and 700 milliliters, although typically filled between 500 and 650 milliliters. It's filled with saline, and if you do use methylene blue in the saline, that is considered off-label use, but is used in order to be able to tell if there's a deflation of the balloon, because it will cause the urine to turn a blue-green color. It's removed endoscopically by aspirating out the fluid from the balloon and removing it through the mouth at 6 months after placement, and it's approved for patients with a BMI of 30 to 40. The Obalon balloon system is a swallowable balloon that's folded inside a capsule, which is swallowed. It uses electromagnetic localization of the dynamic capsule transit into the stomach to actually tell that the balloon is actually in the stomach before inflation. And it's filled with 250 milliliters of a nitrogen mixed gas. 3 balloons are placed over 6 to 12 weeks, and it's FDA approved for a BMI of 30 to 40. And in this animation, you can see the balloon just popped into the stomach out of the esophagus. With endoscopic removal, it's removed 6 months after administration of the first balloon, and this is an endoscopic image of the 3 balloons in the stomach. It does use a 6 millimeter to 8 millimeter injector needle with a converter for suction in order to aspirate the gas out of the balloons, and then a 15 millimeter rat tooth alligator forceps is required in order to remove the balloon out of the stomach. In terms of the weight loss, we see that there's higher weight loss in clinical practice than in the FDA trials, and that's primarily related to the sham-controlled studies. Sham control, what we've learned over time is that in the United States, sham-controlled study design suppresses weight loss in the active arms. And both the reshape and the Obalon balloons were studied in a randomized sham-controlled study design, whereas the Orbera balloon was studied in an open label design. And we can see that compared to the FDA studies, the registry and post-market studies, we see significantly more weight loss in all of the balloons compared to the FDA, in particular, sham-controlled studies. At 12 months, we see similar weight loss between the 3 balloons, regardless of the type of study that was done. And we only have post-market 12-month data really on the Orbera balloon. We don't have post-market study data yet from the Obalon balloon system. However, there is a difference between the balloons in terms of their serious adverse events. And we see that there's consistently a lower rate of serious adverse event for the gas-filled balloon compared to the fluid-filled balloons. And that's true for both the post-market and pre-market studies, the FDA trials for approval, and again, the post-market studies. Although the post-market study is not yet completed for Obalon, both the FDA trial and the registry series showed a serious adverse event rate of less than 1%, so 0.3% and 0.15% in those studies. And the serious adverse events that did occur, it is important to note, were mostly related to nausea, vomiting, dehydration, and weren't anything that required hospitalization or weren't anything that required surgical treatment for. The ellipse balloon is a swallow balloon as well. It's a thin polymer swallowed in a capsule filled with 550 milliliters of saline, and it self-deflates at 4 months and passes naturally out of the GI tract. In a multi-center European registry, including 1,717 patients across 19 centers, there was 13.5 kilograms or 14.2% total body weight loss. In those patients, most of them were able to swallow the balloon, but some of them required stylet assistance to get the capsule into the esophagus. And most of the patients had passages of the balloon out through the GI tract. Some of these patients vomited the balloon up, and there were some patients that required early endoscopic removal, and some patients that required surgical removal because of small bowel obstruction. It is important to note that this was an earlier generation of the balloon, and the current generation of the balloon does have less risk of small bowel obstruction because of incomplete deflation. The Spatz balloon is a silicone balloon that has variable fill between 300 to 900 milliliters and is filled with methylene blue. It has a 10-centimeter retractable, stretchable silicone inflation tube that allows for endoscopic adjustments while the balloon is actually implanted in the stomach. It is endoscopically placed and removed at 32 weeks. In the United States. Outside of the United States, it's approved for longer use out to 12 months. In the multi-center open label randomized controlled trial in the US, there were 288 patients, and about 15% of those patients required downward adjustments, and some patients had upward adjustments that resulted in increased weight loss of about 4.7%. Weight loss at 32 weeks was 14.9% in the device group and 3.6% in the control arm. And most of those patients, so 75% of those patients in the device arm, maintained more than 40% of their weight loss. Serious adverse events occurred in 5.3% of patients, and ulcers occurred in 4% of patients. And in both the ellipse balloon and the Spatz balloon have not yet been approved for use in the United States. Moving on to the non-intragastric balloon gastric devices. We have the Aspire Assist system from Aspire Bariatrics that's similar in concept to percutaneous endoscopic gastrostomy tubes. It's placed endoscopically with the same technique as a PEG tube is placed. Patients aspirate gastric contents 20 minutes after a meal 2 to 3 times a day, and it removes about 25 to 30% of the calories that were consumed at that meal. And we determined that through a study that used bomb calorimetry of the gastric aspirate. But that still only accounts for 50 to 80% of the weight loss. Lifestyle therapy and mealtime behavior changes reduce overall food intake, so patients are actually eating less with this therapy. They also have improved food choices, and we think that this is because of the patients are actually able to see what's coming out, and healthier food choices really do look better coming out of this device than food choices that aren't healthy. And it's approved for a BMI of 35 to 55. And there's the 2 panels of the pictures here demonstrate the different components of the device. There are the components that are implanted. That's in the top panel. That includes the A-tube and the skin port. And then the components on the bottom panel that are only used during aspiration itself. So these are only connected to the patient when they're actually aspirating. In terms of data on this device, we recently published a meta-analysis for the American Society for Gastrointestinal Endoscopy, which looks at preservation and incorporation of valuable endoscopic innovations at specific thresholds. And the Aspire Assist device did meet these thresholds. 4 studies were included at 1 year, with 373 patients in the intention to treat analysis, 296 patients in the per protocol analysis. There were 3 studies that had more than 1 year of data. And in terms of serious and non-serious adverse events, there was 3.8%. So some of these adverse events that were reported as serious did not actually require surgery or hospital stays. Buried bumper in 2.2% of patients, peritonitis in 0.5%, severe abdominal pain after placement in 0.5%, pre-pyloric ulcer in 0.3%, and device malfunction requiring replacement in 0.3%. So in general, very serious adverse events that did not have sequelae associated with them. In terms of percent total body weight loss in the modified intention to treat analysis at 1 year, we have 16.6% total body weight loss. And in the per protocol analysis, we have 17.8 to 19.1% total body weight loss across the group, even out at 4 years, as long as patients are continuing to aspirate. What we really see is that patients are maintaining their weight loss. The transpyloric shuttle is another device, a gastric device, that is not a space-occupying device. It's a silicone sheath filled with a coiled cord of silicone tethered to a small weight. It's placed endoscopically through an overtube and intermittently blocks the pylorus and remains in the stomach for 12 months. It was studied in the United States in a randomized sham-controlled study called the End-Obesity 2 trial, and you can see the characteristics of these patients here. There were 3 groups: the randomized active arm, the control arm, and an open label 32 patient group in the trial as well. And the average BMI was 36 across all of these groups. In terms of total body weight loss, patients got 9.5% total body weight loss in the TPS group and 2.8% total body weight loss in the control arm. There were 6 patients who had serious adverse events, and some of these were overlapping. That included an esophageal rupture with pneumothorax that was repaired surgically, upper abdominal pain, gastric ulcer, vomiting, and device impaction. Those were all managed conservatively. And you can see a picture, the picture's up at the top of the TPS actually in the stomach. All right, suturing and plication devices. We've got endoscopic sleeve gastroplasty that in the United States is performed using the Apollo overstitch device. It does require general anesthesia, argon plasma coagulation to mark the stomach, IV antibiotics, DVT prophylaxis. In a meta-analysis from studies both inside and outside of the US, there were 1,772 patients that were included. Weight loss was 16.5% at 12 months, and at 18 to 24 months, there was 17.2% total body weight loss with a serious adverse event rate of 2.2%, but most of those serious adverse events did not require surgical intervention. And you can see in the bottom image an actual endoscopic sleeve gastroplasty endoscopy video. There's also long-term weight loss that's seen with this study. So in a single center experience in 216 patients, there was over 10% total body weight loss in 61 to 77% of patients when evaluated at the 3-month time point out to the 60-month time point. About 27% of these patients were also on weight loss medications, but the most important thing is that at 60 months, at 5 years, weight loss was 15.9%, and they had really high follow-up for this study, so 89% follow-up at that 5-year time point. There's also the POSE procedure, which is using the incisionless operating platform from USGI Medical. This is an operating platform that uses something called the transport that has multiple ports in it in order to place snowshoe tissue suture anchors in order to place these large plications that have serosa to serosa apposition. The original study with the POSE 1 procedure was not approved by the FDA, and it's now under evaluation using the POSE 2 design, which focuses on the gastric body for tubulization of the stomach. And we can see in these images on the left what the suture pattern actually looked like and the ultimate suture pattern with the plications in place. These images were courtesy of Ramon Turo. In a single center series out of Spain with 75 patients starting the study and 46 out to 1 year, we see weight loss at 12 months of 17.8% and serious adverse event rate of 5%, although this is based off of FDA, what the FDA would actually call it, and that's only because they stayed in the hospital for greater than 24 hours. Otherwise, these were really managed medically, did not require any surgery. All right, briefly on the small bowel therapies. We first have the exclusion of the small bowel with the duodenojejunal bypass liner by GI Dynamics. It's a nitinol anchor with barbs for fixation in the duodenum with an impermeable liner extending 60 centimeters into the small bowel. And the liner is open at both ends, but it really covers up the duodenum. The original trial in the US was stopped due to hepatic abscess, but in a meta-analysis of 14 studies outside of the US, we see significant reductions in hemoglobin A1C, HOMA-IR, and continued hemoglobin A1C reduction even 6 months after explant. They also had significant total body weight loss of 18.9% at explant. And again, there's a new trial that's been started in the US with altered post-implant management to reduce the risk of hepatic abscess. Last device that we'll talk about is the Revita duodenal mucosal resurfacing, which uses a single catheter to cause circumferential mucosal lift and then has hydrothermal ablation. And it ablates hyperplastic mucosa, which we think is contributing to poor glucose control. And again, it's followed by regrowth of normal mucosa. In the first study, the first-in-man study with Revita DMR, we see that there was 39 subjects treated with either short segment or long segment treatment of duodenal mucosal resurfacing in the duodenum. And those patients who had long segment ablation had more improvement than the patients with short segment ablation. And in those patients who didn't stop their medications, they had even more improvement in their hemoglobin A1C at 1.8% total reduction. The other important thing to note is that there was no weight loss in these patients, really less than 3 kilograms of weight loss. So we really can't explain their improvements based off of weight loss. There's also been an additional 2 studies, but the second one being a randomized sham-controlled study in both Europe and Brazil in multiple centers. And we see pretty similar characteristics between the European and the Brazilian cohorts based on their age, race, weight, and BMI. However, there were significant differences in these 2 cohorts, which made them really not similar. And so they were both analyzed together and also analyzed separately because we think the Brazilian cohort really may not have been taking their medications prior to this study. And so just by the fact that they started having better treatment for their diabetes, they had significant improvements. So when we look at the European cohorts, we see that there's significant improvement in hemoglobin A1C, significant improvement in liver fat, but very small amount of weight loss. So we really think that that weight loss is not clinically meaningful and not really resulting in significant, is not causing the improvements that we saw. So in conclusion, there's no shortage of patients for obesity treatment, and endoscopic treatments of obesity are really rapidly advancing. New procedures and devices address current issues, they reduce risk, broader appeal to patients, increased capabilities within the lumen of the GI tract, and we have more data now with multiple randomized controlled trials and long-term studies. Thank you.